Good morning, everyone, and welcome to today's webinar, Prone Positioning, What's New? Before we get started, I'd like to go over a few items so you know how to participate in today's event. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time using the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. I would now like to introduce Tyler Weiss, Clinical Education Coordinator, Assistant Professor, Department of Cardiopulmonary Sciences, Division of Respiratory Care, Rush University Medical Center. Tyler?
So just thank you again for having me here today. We're going to talk a lot about prone positioning in this lecture, a lot about what we've learned about here at Rush. We've did a lot of research surrounding proning, and just some exciting findings that just recently came out with some of our studies. But to start, I just want to mention I have no conflicts of interest related to this talk. I will be talking about some brand names at certain points of time, but there's in no means an endorsement or a de-endorsement of any product. It's just to illustrate a point. But we're going to talk again about the current literature to support prone positioning, including COVID-19, but also just in traditional ARDS. We'll talk about some methods and challenges of placing patients in the prone position. Then we'll also talk about some mechanical ventilation strategies once the patient is prone. And then we'll also look at some current literature to support the use of awake prone positioning, so patients that are not invasively ventilated. I just want to give a shout out to my mentor, Brady Scott, Dr. Scott. We started this presentation way back in 2014, and it has just slowly been added on, and I've kind of taken it over fully now, but some of this initial stuff that we'll be talking about was also created by him, so just wanted to give him a shout out to the presentation as well. So I always think, even though I know everybody on this talk right now probably knows what prone positioning is by now, but I still think it's important to start at the beginning, see exactly what it is and why we do it, and then we'll go into the literature a bit. So what is prone positioning? Well, it's this picture right here. It's a patient laying on their stomach, and we ventilate them in this position as opposed to on their back. So how does prone positioning work? Well, overall, it just alters the mechanics and the way that gas exchange occurs. When we're supine, we have this dorsal lung compression, which I'll get into a little bit more there. And when we prone, it alleviates some of this dorsal lung compression. And then it also improves lung perfusion. And again, I'll talk a little bit more about this in more detail. So when the patient's laying in the supine position, we have this increased pressure at the bottom of the lung, so in the dorsal region, and this is due to this vertical pressure. Gravity is pushing down on the lungs. The lungs are taking the gravity of the heart, abdomen, any internal organs are all pushing down on the lung that is already injured. So this gravity and this downward pressure from the organs compresses the lung tissue, which then creates this shunt. So we have lung units that are collapsed, that are being perfused, which is your definition of shunt, perfusion without ventilation. And this turns into reduced gas exchange, so our PaO2 is naturally reduced, and we see this hypoxemia. In addition to that, we also have some areas of the lung that are well ventilated, and because we have less area and we have just this smaller area of well-ventilated lung, those areas tend to get a little over-distended. And this causes more and more injury with this cyclic opening and closing of alveoli, causing atelectatic trauma, which just exacerbates this whole inflammation process that's already occurring, and we're causing more lung injury, and things tend to get worse. And this is exactly what I'm talking about here. So you have your gasless compartment, which is here in the dorsal region. This is this is a CT of a patient with ARDS. And the dorsal region where it says gasless compartment, this dense white is all lung that is collapsed. And then above it, we have what Dr. Gattinoni famously coined as the baby lung. I'm pretty sure he was the one that first said it, and if he wasn't, I don't care. I'm giving him credit because he is the ARDS genius, so he gets credit in my book. But baby lung, he called it baby lung because this is a well-ventilated area of lung, but the volume is much reduced because of this gasless compartment. So all the pressure that we're given from the ventilator goes to the path of least resistance, which is this baby lung, and that tends to stretch that lung and become overdistended, causing more damage. So the target when we're proning someone is we're targeting this gasless compartment. We want that gasless compartment to open up. So when we prone a patient, we flip them on their abdomen, this helps alleviate that alveolar overinflation that I was just talking about, and it helps alleviate that dorsal alveolar collapse. So as that dorsal collapsed gasless compartment opens up, the path of least resistance is a little bigger now. The area that we can ventilate the lung is bigger, so we have more room for the pressure from the ventilator to go. Therefore, the baby lung is a little bit bigger, and it's no longer a baby lung, and we're not overdistending these alveoli, causing injury. So we have decreased lung injury overall. Just the act of flipping the patient on their belly helps promote lung recruitment, and this is by relieving some of that gravity dependency of the abdomen and the heart, liver, anything pushing down on the lungs. That is now offloaded off of the lungs, so the lungs hopefully have room to recruit. And overall, this helps improve our VQ matching, so our ventilation perfusion dead space and shunting. So as that lung opens up, that dorsal region, we're able to have better gas exchange in those lung areas, and which should ultimately improve our PaO2. And then this last point, perfusion tends to persist in that dorsal region. So in this dorsal region, we have a lot of blood flow here because there's a lot of surface area of the lung. Contrary to popular belief, is it was always thought of when you flip someone prone, the blood flow would then just trickle down because of gravity to this nice, well-ventilated area, and that's how proning works, is that the blood flow will be here once we flip them upside down, and the baby lung will help with the oxygenation. But that was found not to be true. The perfusion of the lung tends to persist in that near the spine, where all that surface area is of the lung. So as that lung opens up, the perfusion and ventilation improves. And I have a great picture here to depict exactly what I'm talking about. So again, here, this is kind of a drawing of that baby lung that I was just talking about, where we have the dorsal lung that's nice and really consolidated, and we have this ventral lung that's nice and open and well ventilated. And you can see this sagittal cut of this patient here is we have this very overdistended ventral alveolus and very collapsed dorsal alveolus. And so we have these large swings in pressure gradients here. And the blood flow, as I mentioned, is more persistent in this dorsal region. So if we have all the blood flow here, but the lungs are completely collapsed, that does us no good, because the oxygen can't be dropped off into the blood, the CO2 can't be dropped off into the lungs. So we need to work on this part, open it up. So we flip the patient over, alleviate all that pressure from the organs, pushing up on the lungs, and it helps start opening up this dorsal region that is now technically ventral because it's up, but it's the previously dorsal region is now opening up, becoming more. We have more homogeneous pressures across the lung, so there's less damage going occurring in the lung, as well as I said, the blood flow persists even though that it's now up, facing up, opposite of gravity. The blood flow still persists in this previously dorsal region near the spine. So as that opens up, we have better perfusion and ventilation in that area, and we should see an improvement in oxygenation. So prone positioning is not new. It has been around for a long, long time. So why now? So again, we started this back in 2014, this presentation. I think everyone knows why we use it now. The big elephant in the room, COVID. Everyone uses it like crazy. But before COVID, proning was not new, but we still didn't use it all that often. So I'm going to explain a little bit about why that is. So in the past, there's been several randomized controlled trials that show that prone positioning improves oxygenation. In fact, up to 70% of patients respond with improvement in oxygenation, which allows us to turn down our FiO2, which we know can be damaging at high levels. So that all seems good, but still, why did people not use it? In addition, we also found that prone positioning can prevent further ventilator-induced lung injury. Again, seems good, so why haven't we used it? This is the big but. In most trials, dating back many years, is that most trials, they showed these benefits of reduced lung injury, better oxygenation. However, these didn't translate into better patient outcomes. So there was no improvement in mortality. Sure, the oxygenation got better, but the patient still died. So, and it's not a benign process. It's a process that involves flipping a patient on their belly. So people were kind of turned off to it. Yes, it makes the oxygen look better, but the main goal is helping patients live. So this is a table. I know it's a busy table, but I'll highlight a little bit of what I'm talking about here. But back in 2000, this is 20 years ago, Gatnoni did a randomized controlled trial on prone positioning, showed no mortality benefit. Another one was done in 2004, 2006, 2009. So it's been studied for years and years, and it was used, for 30 years, even, before this. These studies were done. But again, down here on the mortality, there was no mortality benefit. And when we're looking at p-value, we're looking for anything less than a 0.05 to be a significant benefit, mortality benefit. So it wasn't until 2013 that Guerin and colleagues did the PROSEVA trial, and they published this in the New England Journal of Medicine. And this was the first study that showed that there was a mortality benefit with prone positioning. So a pretty landmark study for prone positioning. This is the study. If you haven't read it, I recommend going and checking it out. It's a very good study. And it really put proning back on the map. And I'll tell you a little bit about the study. So again, previous to this study, proning was used for over 30 years to treat hypoxic respiratory failure. And again, we knew that it improved oxygenation, prevented lung injury, but still there was no mortality benefit. And that is why the Guerin and colleagues did this study. Because people were like, well, why are you doing this study? We've already proven it time and time again that there's no mortality benefit. Yes, it will improve oxygenation and reduce lung injury, but there's still no mortality benefit. But that's exactly why Guerin and colleagues wanted to do the study, and they believe they had a different recipe. So as to how proning might be able to have a mortality benefit. So what they did, and I'll get to that recipe here soon, so don't worry. But so what they did is it was a prospective, multi-centered, randomized control trial, over 26 ICUs in France and one in Spain. A very important aspect of this study is all ICUs had at least 5 years experience. So this was important because it's not like one hospital was more experienced than the other in proning, which could have led to some different findings. So all the ICUs were experienced in proning, and the patients that were included were patients diagnosed with ARDS according to the American European Consensus Conference criteria. This was before the Berlin definition was published when they were enrolling these patients. So they utilized the American European Consensus criteria. And so patients that were intubated for ARDS for less than 36 hours and had severe ARDS as defined as PF ratio less than 150, FiO2 60 or greater, and a PEEP of 5 or greater. And this is the key part of their recipe, though. They also had to be on tidal volumes of 6 mLs per kg ideal body weight. So this is a very key part to this study as to why they found a mortality benefit. And what I want to highlight here, again, is that in these past studies, lung protective ventilation was not utilized. So yes, they proned, they saw this improvement in oxygenation, but no mortality benefit. But in 2001, no lung protective ventilation. 2004, no lung protective ventilation. 2006, they used tidal volumes less than 10 mLs per kg, which we know isn't necessarily lung protective. In 2009, same thing. And it wasn't until 2013 when Guerin and colleagues adhered to the 6 mLs per kg ideal body weight, along with prone positioning for prolonged periods of time, and that is when they found the mortality benefit. So it appears they found the right combination of therapies. And it's not just proning by itself, you also have to make sure that you have lung protective ventilation. And here you can see that we have, this is the mortality benefit at day 28. So at day 28 for the supine group, we had a 32%, roughly a 32% mortality rate compared to 16% in the prone group. And then at 90 days, we had a 41% mortality compared to a 23%. And this is all, again, very significant mortality benefit. So I will say this study came out, again, it was published in 2013, and still people weren't proning. They weren't proning like we think we probably should have been, and there is a multitude of reasons why, but ProSiva trial gave you this study, said this is what you need to do, but people still weren't doing it. So in 2017, the American College Chest Physicians Chest Journal published a paper on the treatment of ARDS with prone positioning, and they recommended that for patients with severe ARDS, they should be proned early in their course for 16 hours a day at least, and with lung protective ventilation therapy. So Chest did its part at trying to help people along, saying we should be doing this. They even in this paper gave you a who to prone, how long, who not to prone, some complications that might occur, and then when to stop. So they really gave you the full package of what to do. But people still didn't prone. So then in 2017, again, later in the year, excuse me, all the critical care societies came together, the ATS, European Society, SCCM, they came together for guidelines and management of ARDS. And they too were asked, should we be proning them? And they said, yes, we should be proning them for at least 12 hours a day with a strong recommendation. So again, they're still, we have the evidence now, but people still weren't doing it. And this is in 2019, and people still, well, I'll get to this in a second, but I took out a slide because now the issue is that now we do prone. But people didn't prone so much that the same authors, Guerin and colleagues of the ProSiva trial, they did a whole other study called the APRONET trial, which was basically, so we showed you that it works, now why are you not doing it? So they did a whole study to basically, they reached out to institutions across the world and asked them, why are you not proning? How many people qualify and how many do you actually prone, and why don't you prone people? And they came up with a whole multitude of reasons on why. Lack of knowledge, hesitancy of losing tubes, or a lot of it came around fear. I was just scared. I didn't know what to do. We didn't know what to do, so we just didn't do it. But I think that's all been solved with COVID, more out of a necessity. But it's just funny that they provided the evidence, and then they even did a follow-up study as I told you guys what to do, and you still won't do it. So let's figure out why. But coming up to 2019, this is some formal guidelines that was in Annals of Intensive Care on the management of ARDS. And I really like this little stepwise approach because it really gives you a really good guideline on how to manage someone with ARDS. So initially, you intubate the patient. You intubate, sedate, and you start them on 6 mLs per kg, and you screen them for ARDS. You get your ABG. You meet criteria based off of the Berlin definition. Let's say with your PF ratio less than 300, acute in nature, bilateral opacities that are non-cardiogenic. So you confirm that they have ARDS, then we should adhere to ARDS-NET protocol, which is, your 6 mLs per kg, limit plateau pressures less than 30, PEEPs higher than 5. And then if your PF ratio is less than 200, you should maybe consider higher PEEP, if that helps. If your PF ratio is less than 150, this is the ProSiva trial criteria for proning. So if your PF ratio is less than 150, you should consider prone positioning or neuromuscular blockers. In this same year, 2019, New England Journal of Medicine also published a study on how neuromuscular blockers don't have a mortality benefit in ARDS. So some physicians have strayed away from paralytics, but I would still recommend them if you're having a hard time adhering to that lung protective ventilation. Because again, that's the part of the recipe. If you're going to prone, is that you need to adhere to that lung protective ventilation. So if you're having issues with that, then I would consider paralyzing them. And then if your PF ratio is less than 80, you should be discussing VV ECMO. If I was to make one edit to this table, I would probably put discuss VV ECMO down at the PF ratio less than 150, because if you prone someone and they don't respond, well, the next step is really, are they an ECMO candidate? So I like to start the discussion a little sooner than later, just so everyone's on board and we're not delaying. But I really like this stepwise approach on the management of ARDS. So now we kind of know the background of why we do it, why it's now been shown there's a mortality benefit. So now it's how do we do it? Well, there's several ways. There's manually. You can just get some friends together and flip the patient. Or there's specialized beds. The main bed that I know of, there might be another bed out there, but the one that I'm familiar with is the rotoprone bed. So that's a specialized bed that you put the patient in, hit a button, and it'll prone for them. There's currently no standard method, so whatever way your institution wants to do it or does do it is fine, because there's really no standard method at this time. The manual proning technique, there's videos out there to show you how to do it. The PROCEVA trial published their own video when they published the study. During the COVID-19 surge, when myself and my fiance actually, who's an ICU nurse, we are the prone king and queen of our institution, we created this process, and to get everyone trained in a very quick fashion, as whole ICUs were being proned, is we created a video. So we filmed with my cell phone, grabbed some people, filmed the process on my cell phone, and I posted it to YouTube and gave everyone my YouTube video. Well, that did just fine, but then the World Health Organization saw that video and they wanted it. And I, in good conscience, could not have my crummy cell phone video posted on World Health Organization. So I reached out to my CEO of the hospital and said, this is what's going on. Can we use the media of Rush, the media camera crew, to film us? So we did that, and we made a really nice prone video, which is this video here that I'm referring to. So it's up on YouTube. It has, I think, close to 600,000 views now, but it's posted. We're proud of this video. It helped out a lot of people, and it's posted on the World Health Organization education site, as well as if you look up prone positioning on Up to Date, they have a video posted there. They have the PROCEVA video, and then right next to the PROCEVA video, they have our video. So it's we're sitting shoulder to shoulder with the PROCEVA video, which is pretty cool. So check it out. We have updated it since then a little bit, but the whole feel of how to prone someone is there. We tweaked a few things here and there during the process. Rotoprone, so similarly to manual proning, so the PROCEVA trial was all done with manual prone positioning. So there was a study done with the rotoprone to see if there was any difference in outcome if you use the bed versus manual prone, and there was no difference found. As long as you adhered to adult lung protective ventilation and prone positioning, didn't matter how you did it, as long as the patient was prone, there was really no difference in terms of mortality and things like that. So, however, in this study, it was not compared to manual proning. So this is the rotoprone bed that I was discussing. So the patient fits into that bed, gets all strapped in, and then you hit a button and it flips them over. So essentially being prone is being prone no matter how you do it. In 2001, though, earlier this year, a study was published that did actually compare manual versus automatic prone positioning utilizing a specialized bed. And they wanted to see if there's any difference anywhere else in terms of the process. And this was a retrospective study which looked at 37 patients, 16 were manually prone, 21 utilized the automatic bed. And what they found, and this is a busy slide, I know, but I'll highlight here what I'm getting to, is that similarly to that other rotoprone study I just mentioned, the outcomes between the two groups were similar because, again, being prone is being prone, no matter how you do it. However, they did find that the patients that were manually prone were less likely to experience interruptions in the therapy, and they experienced less complications. And again, these are both p-values less than 0.05, so these were significant differences. So the manual group had less complications. Those complications were mostly pressure injuries. So they found that there was way more pressure injuries, a significantly higher incidence of pressure injuries in those that utilize the automated bed, specifically on the head, thorax, and lower extremities. They also did find that utilizing prone positioning via manual method saved $78,617 per patient. And that just makes sense. The bed is another piece of equipment. It's expensive. And depending on how it's utilized, whether you own it or you rent it, it can be quite expensive. So the manual proning had less complications and it was much cheaper. But again, when it comes to proning, though, no matter how they're proned, the outcome is the same. So if you're looking to institute a process, or if you have the bed, it's fine, but you just might want to look out for areas to improve skin issues as based off of this study. But again, however you put the patient in the prone position doesn't really matter in terms of outcomes. So when we were developing our process on how to do it, because we actually did used to use the automated bed, and we were moving away from it for a lot of the reasons that were depicted in that study before the pandemic hit. So we were in the process of creating a manual prone process. We started in November, actually, of 2019. And then things started getting a little hairy, and we're like, we need to expedite this and get this going soon because we're about to get hit. And luckily we did expedite it. But what we did is we just went to the literature. What are other people doing? Let's not reinvent the wheel here. So we went to the literature, and these are just some of the things that we went to. We found this study that showed how they do this stepwise manual proning process. I'm just going to click through these because there's a lot of them. But again, if you guys are looking to change your process, just go to the literature, see what people are doing. There's this study that showed, again, an algorithm on how for prone positioning that includes contraindications, adverse events, and special considerations that you might want to consider. And what we did is we basically took all these and we took what we liked and we made our own. And we thought what would fit for us. So this is our process that we created. It's a 4-phase checklist. It's really 2 phases is the meat of it. That's the whole proning process. The other 2 are just the care of a patient when they're prone and care of the patient when they're supine, which is pretty much care as always. But the whole the checklist before we prone, what does each person need to do? So we split it between what does the bedside nurse need to do, what does the respiratory therapist need to do, what does the doctor need to do. And then we have our supplies. Then we have the whole what does the RT need to do during the prone positioning, executing the prone position process, and what does the nurse need to do. And then we have our stepwise approach. And then again, we have our duties for each discipline based off of what phase they're in. When they're prone, what does the RT need to worry about? When they're prone, what does the nurse need to worry about? So again, we just picked and chose what we liked out of these studies and created our own process. This again is another thing that obviously came up a lot, which was the padding of the pressure points and bony prominences. So skin breakdown is a clear issue when proning someone. So again, we went to the literature. What are other people doing? So we started with something I would say a little less padding, and then we just kept adding padding because we kept having some skin breakdown. So this picture I would say is probably a little minimal in terms of padding. This here is the National Pressure Injury Advisory Panel. This was published during the pandemic because proning was being done so frequently that they updated their recommendations for prone positioning. And this adheres to a little bit more of what we do. We actually even added a little more because we thought, you can't really hurt with padding more. So again, this is our process, and we color-coded what needs to go where based off of the type of padding. So we color-coded it, so now you can look at this and say, okay, if it's purple, I need a 4x4 foam dressing. If it's green, I need a 6x6. So it just helped standardize the process So we knew exactly what to grab. If there's new employees, we can show them this. They know exactly what they need to do. And then the airway. Everyone asks me about what do we do with the face, because that's where there seems to be so much skin breakdown. So this is our step-by-step process on what we do to pad the face for prone positioning. So we use this. This is a polymem, typically used around trachs, but we use it and we'll put it over the nose to help protect the nose and kind of the septum area and the philtrum. And then we add some foam dressing to the cheekbones. We use a cloth endotracheal tube holder. This one's by Dale. Again, I don't work for Dale. They don't pay me. This one seems to work for us. I know that there's other ones on the market that are cloth. There's just not really hard plastic on there, which helps out. So we place that on, and then we just add more padding over top of the other padding is essentially what we did. And our patient, by the end of it, should look like the picture on the far right. And then we use a waffle cushion pillow, the one that you would typically put on a chair for a patient to sit on. We fold that up, wrap it in a chuck, and that's what we rest their head on. So once we developed this during the pandemic, everyone, we got the hang of it, but man, we had, about 100 patients ventilated and 85% of them were being prone. So that's a lot of prone patients. That's probably enough prone patients for a career of respiratory care, of critical care. But we were doing it all at the same time. So it got to be a bear for bedside staff, the respiratory therapists and the nurses. So myself and my boss, Ankit Patel, we came together and was like, can we create a team somehow that can go around, and that is all they do, is they will just alleviate the bedside staff and we will just prone and supine and all day. And so we met up with some nursing leadership as well, and we had a pool of nurses and physical therapists, occupational therapists that weren't really doing anything because everything got canceled. So we had OR nurses, interventional radiology nurses, and techs as well from OR and IR. We had PT and OT that weren't doing anything during the pandemic, but they wanted to help out. So we utilized them. We brought them together and created this multidisciplinary prone team. The one rule to it was that there had to be a respiratory therapist on the team at all times. So the respiratory therapist would be the one. This was led by a respiratory therapist, and everything was directed by the RT, and they managed the airway. So we trained up the physical therapists, occupational therapists, OR nurses, and we got rolling with a team. And this is our team here. We even had a cart with lights on it with some music. So it was a little bright spot during the pandemic. Everyone liked hearing the music come in, and they knew the prone team was nearby to come save the day for the prone patient or supine a patient. So it helped out a lot, alleviating some of that workload. But we'd have a cart with all of our supplies. This is a prone team, the respiratory therapist at the head of the bed, and another RT and a couple nurses and occupational therapists. So them in action, and this is me, and these are all PT and OT. That was the prone team for the TAVE, PT and OT and RT. So again, it was something that we were able to operationalize, luckily because we had the resources of this pool of clinicians that were really kind of out of work at the time, but looking for ways to help. And what we found, we did a survey to see how this went, if it was something that we thought went well that we could utilize. And some notable findings were team members noted that more direction from the RT correlated with a better organized and coordinated turn maneuver. So really having good leadership with the respiratory therapist was key. And then we also just showed that that utilizing this team-based approach is feasible during high times of need. In terms of prone team recommendations, so during this study we did find some areas that we might be able to improve on in utilizing a prone team, and that is making sure that they truly are adequately prepared before joining the team. This was implemented in quite a high stress time, so we basically were at the time we're like, welcome to the team, you'll learn as you go. We'll help you through it. But familiarizing them with the process a little bit ahead of time, having a buddy to help them is something we'd probably do in the future if we had to, knock on wood, do this again. Also just elicit questions and some check-ins throughout the process if there's any concerns. Something that we actually do, and we actually ended up doing during the prone team, was we did a timeout, which basically just made sure everyone was on the same page. So we're going to move towards the ventilator first, then we're going to move the patient towards the window, and just so everyone kind of knew the direction of the turns. And then also if just anyone had any concerns before we did it. Another thing, and again, which kind of came fluidly during the pandemic, is we got in this groove where, okay, Tyler, we know Tyler's doing the airway, and Ellen is going to do the CHG bath, and so is going to do the padding, and we just kind of got our roles and just ran with it. And we were like a fine-tuned machine. So just making that an actual thing, just saying, hey, before we start the shift today of prone team, I'm going to have airway, you're going to have this, you're going to have this, and that's what you're going to do on every patient. And then an interesting finding that we found was that, me as a respiratory therapist and part of the prone team, when I wasn't on prone team, I was still caring for these patients in the ICU. So I was able to see their outcomes and track their progress. Whereas the OTs and PTs, OR nurses, they were just on the prone team, and they were invested in these patients, but then they weren't really able to see the outcomes. So they expressed that they would have liked to follow up on how the patients did. So that's something that we would probably work on in the future. So now we'll get to some training, and I promise we'll talk about COVID and our findings. I'm saving the best for last. But training, so how do we train? This is something that we did actually when the Prociva trial came out, because we were thinking we were going to move to this manual prone process at Rush. This was back in 2014, 2015. So we had some students do a research project on how to train someone on how to prone. So this is me. Hopefully you guys can see. I see someone might be having a hard time seeing picture, but this is me. So we did really high fidelity simulation, made it look like I was intubated. I think we did a good job. I think it looks real. Had central lines in, I had peripheral lines, I even had a fake Foley. So made it as real as possible, and I acted paralyzed basically. And we had our pulmonary critical care physicians, we had respiratory therapists, and we had nursing come in and prone me. And we learned the process together on how to manually prone someone. We also utilized a little bit bigger person than me. I'm not that big. I'm 5'6", 165 pounds. So people are always like, well, that's not your typical patient, Tyler. And I said, well, we had a 6'2", 250-pound guy that was in the bed, other bed that, they would practice on me, and then they'd go to the little bit heavier, bigger patient to try to prone. So we utilized this method, and we found that by doing a pre-test and pre-confidence level, post-test, post-confidence level intervention, that clinicians cognitively knew more about proning, and they also were more confident in the process. This is just the checklist and stuff that we utilized for this study. And again, I mentioned this is how we ended up training. This is the professional non-cell phone video that was created, and this is my nursing colleague Liz, who volunteered to be the prone patient this time. But we utilized this video to train all of our staff. So we would have them, we'd send them this video, you need to watch this, and this is basically your crash course proning training, because so many people were being proned, we needed something done quickly. So now once the patient's prone, we need to think about mechanical ventilation. I've alluded to it this whole presentation is we should adhere to ARDS-NET protocol. So lung protective ventilation, we should try to find optimal PEEP. It's really hard to figure out exactly, it's controversial on how to find that, even in the literature. But whether it's you're looking at compliance, you're using esophageal manometry, looking at transpulmonary pressures, decremental PEEP, stress index, whatever you use, you just want to try to find optimal PEEP. And then when you prone someone, you may see your peak and plateau pressures increase, and it's actually almost expected. And so don't panic. It'll probably happen. Don't panic. And this is likely due to decreased chest wall compliance, because now we're laying on our abdomen, so our chest wall is not able to expand as much. So you may see this increase peak and plateau pressures, and you also are probably mobilizing secretions by doing that flip. So give the patient a good suction and see what, hope you might see some decreased peak pressures. Over time, you should start seeing a decrease in peak and plateau pressure, and that's probably attributed to alveolar recruitment. I also like to use this slide as just a little warning on to don't panic if the patient desats, and desats pretty significantly. Especially our COVID patients. We often got patients from outside hospitals at our institution with the report that we tried to prone them, they didn't tolerate, so we flipped them back. We're sending them to you for an ECMO consult. And we would receive them and we would prone them, and they would desat pretty bad. But we give them we just flipped a critically ill patient from their back to their belly. I would be shocked if they didn't desat. So if they have a pretty significant desat, just be patient. Give them, obviously pre-oxygenate them, but give them a couple minutes to start coming up. If you see that the sats start coming up the right direction, then just be patient. Don't be too quick to abandon the prone position. Obviously, if you flip them, they tank and they're not coming back, the sats aren't coming back, then you're going to have to flip them back over. But a lot of those patients that they said didn't tolerate proning actually did tolerate proning and ended up not needing to be cannulated for ECMO. And it's just speculation on my part, but I have a feeling that some of them thought they didn't tolerate because they had that pretty severe desat when they first flipped, and then they abandoned it a little too early. Again, speculation, but I think it could be happening. So I like to just warn people, just be cautious of that. How do we know if the patient responded? Well, we'd like to see a 20% increase in our PF ratio. So this is, you look at your ABG before the patient's prone, and that's really the ABG that you're using to dictate whether your patient needs to be proned. So if your PF ratio is less than 150 on the appropriate vent settings, and you prone them, then you get an ABG. At our practice, we do it just 2 hours after we prone, and we'll check an ABG. But an hour, 2 hours after they prone, get a gas and see if their PF ratio increased. If it increased by 20%, awesome, they responded. If it didn't increase by 20%, don't panic, just be patient. Again, some patients might respond a little longer, but most usually you'll see within the first hour or so. But I've seen patients respond not all the way into the 14th hour, and then they finally respond. You should discontinue therapy once you're really not meeting prone criteria anymore. This is our criteria: PF ratio greater than 150 on a PEEP of less than 10 and a FiO2 less than 60. So if you're meeting this criteria while you're supine, then we don't need to prone you. But we'll keep assessing, because if you all of a sudden meet criteria again, then we'll prone again. And then if you prone and the PF ratio decreases by 20%, so it actually gets worse, then we should probably discontinue supining. If it gets a little bit worse, again, just be patient. If it's just minorly worse, just be patient. But if it gets significantly worse, like more than 20%, then you should probably just abandon it. And then lastly, if any complications occur during proning, so cardiac arrest, tube dislodgement, you're going to have to flip them back over. I promise, we're in the COVID era now. Okay, so what have we learned about proning in the COVID era? So I know another busy slide, but there's been always the controversy: is COVID-19 ARDS the same as traditional ARDS or non-COVID ARDS? And the ProSiva trial was done in non-COVID ARDS, obviously. So people wondered, like, okay, well, yes, COVID patients develop ARDS, but does it really act the same way? So this was a study published this year, 2021, and they looked at over 2,000 patients that were proned, and they looked at their outcomes. And what they found was of those 2,338 patients, 1,017 of them died. Let me see here. 1,017 of them discharged alive, and 1,101 died. So about 43% survived, 47% died. But what they did find is that those who were proned earlier, within the first 2 days of ICU admission, had a lower risk of death compared to the non-prone patients. So again, this is a picture showing those that were proned early had a higher percentage of survival compared to those not proned early. And those numbers really do mimic similar findings to non-COVID ARDS. And then this is a study that myself and colleagues published. I actually believe we were one of the first prone positioning in COVID-19 publications out there. And what we did is this is the first part of my PhD dissertation as well, is I looked at prone positioning in patients with COVID-19, but I looked at the serial sessions and how they responded each time we proned them. Historically, what we do is if we prone a patient and they have a good response, then we label them a prone responder and we just keep proning them as long as we see some sort of response. However, I wanted to see, I looked at the first 3 prone sessions that we did on patients and to see if there was a difference or something significant in the times that we proned a patient. So I looked at 42 patients. This is just the first month that we proned. I separated them into 2 groups, treatment success and treatment failure. Treatment success was discharged alive. Treatment failure was either death or cannulation for ECMO. And what I found was that if the patient didn't continually have a significant response like that 20% PF ratio change, they had a markedly reduced if they had a markedly reduced response rate, then they fell into the treatment failure group. And this is proving my point, as just because they responded the first time doesn't mean that they are prone responders forever. So this for the first prone session, the treatment failure group on average had a positive response of 41% in their PF ratio. However, the second time that percentage dropped from 41 down to 7.6%. However, the treatment success group, they initially had a 63%, and then they continued to have a positive response with the second prone position, which was 54%, and third was a 50% response. But it was that second prone session that we found a significant difference between groups. So this tells you that the importance of assessing each prone response, because if they don't have that response, that 20%, based off of these findings, they have a high likelihood that they're going to fail and either die or end up on ECMO. So this might help you guide care a little bit better, escalate care better. But also, I wanted to know why. What's the difference between these groups? They were similar in every other way. So what is the difference between the group? And that is what I'm studying right now for my PhD, is the mechanism of response, to figure out what's the difference between these groups. Now I'm going to get to awake prone positioning, because this was something that was done a lot, and we were trying to figure out, does it actually work? So back when hospitals started doing this, my colleague and actually my mentor on my PhD, Dr. Jay Lee, who's a respiratory therapist here, she had the idea. She's like, I want to do a randomized control trial. Everyone said she's crazy. You can't do a randomized control trial right now during a pandemic. But she said, for lack of a better term, screw you guys, I'm going to do it. I'm going to at least write it up. And worst they can say is no, that I can't do it, the IRB. But she got approved. But before she did that, she looked at she looked into the literature, and she published a systematic review on the use of awake prone positioning in non-intubated patients. And what she found was that oxygenation appears to improve. However, these improvements in oxygen don't appear to have any translation into reduced rates of intubation or anything to do with mortality, good or bad. So again, this created her curiosity into, we need to do a randomized control trial. Yes, we have a improvement in oxygenation, but it's not translating to outcomes. So we did a randomized control trial here at Rush, and it ended up gaining attention from other countries, so they joined on. So this is a national randomized control trial in which we randomized people into either standard of care, which was to remain supine, or prone. And we just recently published it in Lancet. So this again was a respiratory therapist driven research, and we published in Lancet, which is a massive journal. So I just have to give kudos to my respiratory care colleagues that we can publish in high-level journals. This whole, just because I'm a respiratory therapist, mumbo jumbo's got to go out the window. So I'll tell you a little bit about this study. And what we did is, patients were included if they hit high flow nasal cannula. So this study was prone positioning in patients with COVID-19 on high flow nasal cannula therapy. And we targeted an SpO2 of 90 to 95%, and we utilized SF ratio to meet criteria because we didn't want to stick these patients to get their actual PF ratio. So a SF ratio of less than or equal to 315 was, which is loosely correlative with a PF ratio of less than 150. We utilized that as criteria to meet criteria. And then if they met criteria, we would talk to them and we would ask for their consent. So I have to give props to all the patients out there that consented for our study because these findings couldn't have been done without them. Once they were randomized, we would pull an envelope and determine whether they need to prone or whether they need to stay on their back. And we randomized 567 patients into the prone group and 559 into the standard of care. And what we were looking for was treatment failure. So we were looking at intubation or death within 28 days of enrollment. And the findings that we found were exciting for prone positioning. So this first graph is basically showing the percent of survival without treatment failure. So again, treatment failure was intubation or death. And we found that the chance of survival in the wake prone group was higher without failure compared to the standard of care. Intubation was less, or their chance of survival was higher without intubation in the prone group. The mortality, their chance of survival without mortality, essentially, was higher in the prone group compared to the supine group. And then lastly, the ability to wean off high flow nasal cannula was higher in the prone group compared to the supine group. And these were all significant findings. So from this, we recommend prone positioning, awake prone positioning on your patients that reach high flow nasal cannula as a standard of care for your COVID-19 patients. So if you have a patient with COVID-19 that hits high flow nasal cannula, then start to prone them. We found that if they were on less than high flow nasal cannula, it didn't really make a difference. But we would recommend doing it as standard of care. We did some further analysis in this study, and myself and colleagues published another study, early versus late awake proning. So we looked at that data and we looked at the times on when they reached high flow nasal cannula and when they were proned. And we looked to see if there was a difference if someone was proned a little bit later versus earlier in their outcomes. And what we found here was the time to awake prone positioning from high flow nasal cannula, as we waited longer, mortality went up. And this was a significant finding as well. So if we proned them earlier, the mortality was lower compared to if we waited 36 hours, it was much higher. We did find, though, that there really was no difference between the timing of proning and intubation. So that was really all over the map, but the real significant finding that we found, if you prone them earlier, they have a higher chance of survival. So, and again, here is just showing that the earlier that we prone them, you have a higher survival probability as depicted by the red line, as opposed to the late prone positioning depicted by the blue line, you have a lower probability of survival. So to add to our standard of care, we also would add prone them early and often, early being within the first 24 hours of use of high flow nasal cannula. So once they meet that high flow nasal cannula, get them proned as soon as possible and as often as you can. And with that, I conclude my presentation. I am on Twitter, LinkedIn. Feel free to reach out with questions or any experiences you guys had. And thank you for listening. And I will field some questions now. There's a few over in the Q&A. So I'll just get started on some of them. So from Alex Benson here, says, do you lift the head of the bed 15 to 30 degrees in the prone position? And if so, what circumstances? So yes, we do. We do a reverse Trendelenburg about 10 to 20 degrees. And this really is mostly to just help with skin breakdown. It helps alleviate swelling to the face. So because again, just the fluid helps, the being in reverse Trendelenburg helps less fluid build up in the face and swelling, so it can help with skin breakdown. Does prone positioning pose the same benefits in neonates? So that's interesting. I am a full 100% adult therapist. The word neonate makes me kind of shiver a little bit. So I don't deal with neonates at all. But it's interesting, with neonates, we prone them all the time, right? They're easy to prone. But to my knowledge, I don't think there's any literature out there in terms of proning, the effects of proning neonates. And that's probably because they're prone all the time. They're always proned, I feel like. Whenever I did my NICU rotation, neonates were always prone. They were always laying on their belly. So I don't have a straight answer for you on that one. Let's see here. Talia, critical care PTs and OTs were quite busy during the pandemic, specifically providing guidance for positioning once prone in order to prevent skin breakdown and peripheral nerve injury. Yeah, exactly. So they were too at our hospital. We actually, in our order set, we added it's an automatic PT OT consult. If a patient gets prone, they get a consult in, and they will act as they'll come in and make sure that the patient is optimally positioned. Now, we kind of killed two birds with one stone and just utilized the PTs and OTs in the prone team to do that for us while we're in there. But yeah, at our institution, they weren't as busy as normal. But then once things slowed down, they went back to more regular work, and they were seeing these prone patients all the time. What was average daily duration in prone position? 16 hours is typically what we do. 16 hours prone is our protocol, and then 2 to 4 hours supine. So we'd check a gas, an ABG 2 hours after we go supine, and that'll be kind of our reassessment gas if we need to go prone again. And if they don't meet criteria, we might check a gas at 4 hours, and we just kind of keep an eye on them. And if they meet criteria again, we'd prone them again. But we would do at least 16 hours. There is some literature actually out there with some prolonged, like greater than 36 hours with COVID-19, that has shown some benefit. But again, that's with you're very severely ill. Indication to stop proning, I talked about that a little bit. It's pretty much if your PF ratio is no longer meeting criteria, and also if there's some emergency, or if your vent settings, you might have a PF ratio of less than 150, but if your vent settings are really low, then you might not prone. So if you have 40% oxygen, PEEP of 8, and your PF ratio is in the 150 range, I don't know what that is off the top of my head, but you probably won't prone, even if they're less than 150, because their vent settings are pretty low. So you really also want to make sure your vent settings meet the criteria. So 60%, at least 60% FiO2, and per the ProSiva trial, a PEEP of 5 or higher. We utilize a PEEP of 10 or higher at our institution, but that's because we use a PEEP of 8 as our baseline at Rush. At Rush, 8 is the new 5. So we just made 10 our criteria. But essentially, vent settings, low vent settings, plus the PF ratio is when you discontinue. This one, so the average duration of COVID-19 pneumonia ARDS patients, oh boy, days-wise, it's that I don't have that number off the top of my head, but there were some patients we proned 13, 14 times, to be honest. But from my data, I found that really after the third prone session, the benefits kind of level off. But there were some patients that still had a pretty good response past that third prone session, so I'd still recommend at least still doing it as long as they're still responding. Keep doing it. But as soon as they stop responding, it's kind of futile. Do you think awake prone can delay the need for intubation? So I just mentioned that. I think I answered that question in that last study earlier. So an earlier prone positioning did not really show a need, a difference in need of intubation, but just the mere awake prone positioning, no matter when you do it, did show a decrease in intubation. But when it comes to early prone versus late, they really didn't see a difference in intubation. But awake proning, yes, did show a a reduction in need for intubation. So this is a tough question for the any optimal awake proning duration do you suggest? I would suggest as long as they can tolerate. The other countries that participated with us, like Mexico and France and Canada, they had a good success at just proning their patients. They would stay prone. Here in America, I think it speaks to the American personality, is we were more, adamant at just doing what we wanted. So the patients, is what I'm saying, is they would just prone however they felt, and then they would be sick of it and not want to do it anymore. Didn't listen very well. But longer, the better. Randy, yes, I can send you reference. If you just shoot me an email, I can get you whatever you want. And then, do you prone for multiple days at one time, given that it is lung protective as compared to supine? So no. So the longest that we'll really do is at least 16 hours. We won't necessarily prone people for days, because we also want to assess if they're getting better. If they're better and don't need it anymore, then we won't do it, and we'll start waking them up, because, again, proning is not a benign process. Flipping them over takes manpower, a lot of medications usually. They don't have to be sedated fully and paralyzed, but they need some sedation. So we always want to at least check and make sure that they responded, and see if they need subsequent time. So, and we also give them a break for their skin, just air them out a little bit. Do you increase PEEP to avoid de-recruitment when turning from prone to supine? No, I typically don't. I will assess my lung compliance when I go supine. Typically, I find that the patient does need a little more PEEP once they go supine, but I don't prophylactically do it, because some patients don't need it. But what I'll do is, if they go supine, I'll adjust my PEEP a little bit, look at my compliance, and pick what PEEP has the best compliance. And then I'll do one more, because we have one more question, and then we're over time. But had a severe ARDS scenario where severe respiratory acidosis was the primary issue rather than hypoxemia. Are there studies that support proning in this instance? None to my knowledge. It's mostly revolved around oxygenation, but you could argue the fact that improving your VQ matching can also improve your ventilation. If you proned and they still didn't get better, I would be concerned with increased dead space. We know in our COVID patients, we see a lot of PEs, which is just full-on dead space. So typically we're proning for oxygenation, not necessarily ventilation, but you will at times see your ventilation get better, but I don't know of any specific studies. All right, I'll just do one more because it's a quick one. Do you find any specific modes of ventilation work better in conjunction with prone? No. It's just as long as you're adhering to the 6 mLs per kg ARDS-NET protocol, you can achieve that with any mode, essentially. Volume control, pressure control, PRVC. We don't use a lot of APRV, but I'm sure people use APRV. Can't speak on APRV or bi-level with proning. But any of your conventional modes will work just fine as long as you're adhering to the lung protective ventilation. All right, that's it.
All right, thank you, Tyler. Thank you, everyone, for attending today's webinar, Prone Positioning, What's New? If authorized by the sponsor, the webinar will be posted to the ATS YouTube channel in about 2 weeks. On behalf of Fisher and Paykel, our presenter, thank you for joining us today, and have a great rest of your day.